Hi everyone, I hope you've had an amazing week and welcome back to GP Made Easy. My name's Dr. Daniel Follows and I'm a fully qualified GP working and living in the UK. So, as you can see behind me with all of these little bits of equipment, I'm going to be covering asthma today to help you be able to diagnose and manage it at any age. But before we go into the video, don't forget to like, comment and subscribe so I know that you're enjoying this content. But anyway, let's get on with the video. So what is asthma? Well, it's defined as a chronic respiratory condition that is usually associated with airway inflammation and hyperresponsiveness. It affects about 2 to 3% of people in the UK. And the reason why we're so concerned about it is because currently about 3 people die every day from asthma. So, who's at risk of developing asthma? Well, anyone who has a past medical history or a family history of atopy. Gender, for example, in children, it's more common in males, whereas in adults it's more common in women. If the child was born as a preterm delivery, or if they had a low birth weight when they were delivered, people who are obese, people who have been exposed to smoking, whether they've smoked themselves or just had passive smoking, and anyone who's had allergen exposure. So, how might someone with asthma present? Well, they may come in with a history of a wheeze, a cough, noisy breathing, chest tightness, or feeling out of breath. And with some of these symptoms, there may even be a variation. For example, it's worse in the morning or night time, or is seasonal. And there's a history of any trigger making it worse. They may have a past medical history or family history of asthma or allergic rhinitis. And on examination, you may hear a wheeze, but even if the respiratory exam is normal, that does not exclude asthma. The actual way to diagnose asthma is with the clinical symptoms and one objective test, which we will cover shortly. While you're awaiting the test to confirm asthma, you code the patient as suspected asthma in the notes. So, what tests do we do to confirm asthma? Well, it varies depending on age, and we'll cover them all step by step. But while waiting for the diagnosis, if someone is highly symptomatic or unwell, you can start treatment in the interim. So, for children under 5, it's acknowledged that it can be quite difficult to do tests in these children. You can try to do an investigation if you want, but if they fail it, then you move on to the next step, which will be going on to the treatment algorithm, which we'll cover later in the video. It is recommended though as well to try and repeat the test every 6 to 12 months until they are able to fully do the test. The guidance also recommends for under 5s that if they've had 2 or more attendances to A&E over the last 12 months with a wheeze, then to refer them to see a respiratory physician. So, moving on to 5 to 16-year-olds, I've got the table up here just for reference as well so you can follow along. For the interpretation of them, I'll let you read that in your own time. So the first line investigation, if it's available, is to get inhaled nitrous oxide organised. But if that's not available, then you go ahead and refer them for a spirometry. If that's not available or there's quite a bit of a waiting list, then you can move on to doing peak flow readings, which I'll cover that shortly. And then if peak flow readings have been normal or not shown signs, then move on to doing skin prick tests for house dust mite or total IgE, and if either of them are raised, then it confirms diagnosis of asthma. And if all of these investigations are negative and you still suspect asthma, then you refer them to the respiratory physician. So moving on to 16 years and over, so you start off with either getting a full blood count to get an eosinophil level, or inhaled nitrous oxide if it's available. Then if that doesn't show asthma, then we move on to spirometry. And again, if that is normal, then you move on to peak flow readings. And then finally, if that's still normal and you suspect asthma, then you refer them to the respiratory physician for a bronchial challenge. So moving on to peak expiratory flow rate, I'm going to demonstrate how to do it and how long they recommend to do it for. So this is the classic one that I'm sure that we're all aware of. It's got numbers down here with a little slider. So whenever you get a patient to do one reading for this, you get them to make sure the slider's down to 0. They pop the little breathing tube on the end, then they hold it horizontal, take a deep breath in, lock it round their mouth, and then blow out and hard as fast as they can. So it'll be, and then they read the value, so it's gone up like that. And when they're doing this, they do it 3 times in the morning, 3 times in the evening, record the highest of the 3 each time, and do that for 2 weeks, and then hand in the values. So one thing to be aware of is that 1 in 5 cases of asthma can be caused by occupational asthma. So in the history, don't forget to ask about their work and whether their symptoms are better, worse, or the same on days off work. And if there is suspicion of occupational asthma, please refer them to the respiratory physician and get them to get in contact with their occupational health team. I thought I'd also show you a newer type of peak flow meter I've been shown, which was quite useful, so I thought I'd show you, see what you think. It's called an easy peak flow meter. Comes in a box like this. So you open it, it's got the classic peak flow meter with the slider. It's got the little mouthpiece at the end. But what's good is it's also got these little colours here, so based on what their maximum is, they can then set these to help them know when they're having either a moderate exacerbation, acute severe, or life-threatening asthma exacerbation. So this is something to maybe consider when prescribing for patients, so they can use it themselves at home. So moving on to the management of asthma. So today I'm just going to cover all the treatment algorithms for each age group. So during this video I'm going to give you some examples of inhalers as we go along, but please remember to check your local prescribing formulary if there are any differences or what their preferred inhalers are. Now in terms of inhaler technique, I'm going to cover that in another video. So moving on to the management of under 5-year-olds, so I've got the table up here. You go straight on to giving them an 8 to 12 week trial of a low dose inhaled corticosteroid. So the example is a Clenil 100 inhaler, 2 puffs twice a day. If they've not had any response, then you need to think of an alternative diagnosis for their symptoms. If they have had a response, then you trial them off it for 3 months, and if the symptoms come back, they can go back on the inhaler. So start off at the low dose again, and if symptoms are still not controlled, then you can move up to the moderate dose of the inhaler. If they're still not controlled on moderate dose steroid, then move on to adding in a leukotriene receptor antagonist. The commonest one we use is montelukast, and again, give them an 8 to 12 week trial. If their symptoms still haven't improved, despite this being added on, then the guidance suggests to refer them to a respiratory physician. So what's classed as uncontrolled asthma? So in any age group, it's classed as any exacerbation requiring steroids or frequent regular symptoms, for example, needing to use the reliever inhaler 3 or more days a week, or if they have 1 or more episodes of nighttime waking. As you can see with any stage of treatment for an under 5-year-old, they can have the blue inhaler with their regular preventer inhaler. So moving on to 5 and 11-year-olds, again I've got the table up here. So there is a mention of MART, but I'm going to leave it for this video because I've had a look at the guidelines and there aren't actually any MART regimes that are licensed for this age group. So I'm going to focus mainly on the right hand side of the table. Again, as before, with any treatment step, they're allowed to have a reliever inhaler, the blue salbutamol inhaler with it. So first, just like under 5s, we start off with a low dose inhaled corticosteroid, and then if they don't respond to that, we add in a trial of montelukast again for about 8 to 12 weeks, and we stop it if they've had no benefit or if they've not tolerated due to side effects. The next step, if they're still uncontrolled, would be to move on to giving them a combined inhaled corticosteroid with a long-acting bronchodilator, for example, Seretide 50, 2 puffs twice a day, or Symbicort 100/6, 2 puffs twice a day as well. So they have no improvement with the low dose, then you can move up to a moderate dose, joint inhaled corticosteroid and LABA inhaler, and if they're still not responding, then you would refer to a respiratory physician. So moving on to 12 years and above. So again, tables up here. So the first step is if they have very mild symptoms, you can just give them a combined inhaled corticosteroid with long-acting bronchodilator, just as and when they needed. This is called the air therapy. We'll go over examples of them shortly. So the mainstay of treatment for this age group is the MART regime, which stands for maintenance and reliever therapy. And they just have one inhaler, a joint inhaled corticosteroid and LABA inhaler that they use as both a maintenance and a reliever, because the evidence has shown that the formoterol that's used in these inhalers has the same time of onset as salbutamol. So up here I've got some examples of MART regime inhalers that you can use, and it's got the dosing underneath and even the amount of times they can use it as a reliever a day. So first of all, they recommend to use low dose MART regime, and if their asthma is still uncontrolled, then to move on to moderate dose. If it's still uncontrolled on this, then they recommend you either get an inhaled nitrous oxide level or a eosinophil count. And if either of them is raised, you can either trial giving a leukotriene receptor antagonist or a LAMA inhaler, which I'll put some examples up here, where you can either give them the LAMA separately or give them Trimbo with all three components combined. And if they don't respond to it, you then refer them to a respiratory physician. If either the inhaled nitrous oxide or eosinophil count is raised, then they just recommend referring them directly to a respiratory physician. So moving on to an acute exacerbation of asthma, can either be a moderate exacerbation, an acute severe, or a life-threatening exacerbation. And I'll put some tables up with the symptoms. So got moderate, then we've got acute severe, and then we've got life-threatening. So as you can see from the tables, the main differences are in the acute severe and life-threatening, where between adults, children and 2 to 5 year olds there's slight different cut-offs for the heart rate and respiratory rate. So have a look at the tables each individually. So anyone who's got acute severe or life-threatening exacerbation, you should be getting the emergency trolley out to resuscitate them, while at the same time calling 999 to get them into hospital. For moderate exacerbation, if you think they're safe enough to be managed in the community, then the mainstay is steroids, and you can add on antibiotics if you think it's clinically indicated. So the main steroid we use is prednisolone, and for adults the dose is 40 to 50 milligrams for 5 days. Children aged 6 to 15, it's 30 to 40 milligrams for 3 to 5 days. And in children 2 to 5, it's 20 milligrams for 3 to 5 days. And in children under 2, it's 10 milligrams for 3 days. Now, it does recommend you can extend the steroids until their symptoms have settled. And if someone has only used them for less than 2 weeks, there's no need to do a reducing regime. They can just stop the steroids. So, with any young person who's been diagnosed with asthma, please get them to really consider their future careers so they don't get occupational asthma as well. Now, for reviews for asthma, it's recommended to review them every year or after every exacerbation, and that each patient should have their own asthma action plan. Now, I've done some research and found some on Asthma UK. I've got an example of one here, and they have many different ones for all the different regimes, and I'll pop the link down below so you can get them as well. They are free for any healthcare professional, so you can incorporate them into your practice. Now, with all these changes in the guidance as well, it probably would be a good idea for each person at their practice to do some up-to-date audits to improve the care of asthma patients, and I've got some examples of some you can do below, that you can do for your QIA projects or recommend to students. So, here are some of the examples. So you could do a search if anyone's got a code of asthma and if they've missed their annual review, and what you can do to improve their attendance or get them in. If they've had 2 or more courses of oral steroids in the last year and missed a review, you could work out a system to get them invited in for a review. If they've had an asthma-related illness coded on an out-of-hours or A&E letter, you could then get them invited into the practice for a review. And last but not least, you can check people who are diagnosed with asthma and check if they've got a personalised asthma plan in their notes. And if not, you can devise a plan for that. So that's it for today's video. I hope you found it helpful and I hope you've now gained a better understanding of the diagnosis of asthma and its management. I've linked down below in the description of this video all the resources, and I've also linked the nice guidance where you can go and get a copy of all the diagnosis and management tables. Don't forget to like, comment and subscribe so I know that you're enjoying this content. I'll make more for you. And if you have any topics you'd like me to cover, then please comment down below. I'm also on Instagram, same name, GP Made Easy, or if you'd prefer, you can contact me via email and the email address is just here. Well, I hope you guys have an amazing week and I will see you in the next video.